Good afternoon, morning, everybody. My name's Emily Field, and I'm an evaluator at USET. And if you haven't done so already, I'm going to invite you to mute yourself, and please don't take offense if we mute you during the call. Please feel free to ask presenters questions directly by unmuting yourself or in the chat. And if you're not comfortable asking them directly, you can send it to one of us and we can ask them anonymously. I also shared a roll call survey. If you are looking for continuing nursing or medical education credits, please complete the survey, and I'll just send it again. And the session is being recorded. Towards the end of the hour, I will share another survey. This is different from the roll call survey, to get some feedback from you on how we can improve these sessions. And that's all.
Thank you, Emily. I'll go ahead and announce the presenters that we have today. We have Dr. Jorge Mera from Cherokee Nation, Imani Ransby from USET, and Dr. Richard Bunio from Cherokee Indian Hospital Authority. Sorry. And we'll go ahead and get started with Imani if you want to share your screen.
Hello, can everyone see my screen? Okay, great. So good morning, everyone. I will now provide a brief update on the Nashville area COVID-19 epidemiology and just give an overview of what we are currently seeing in the USET region as it pertains to COVID-19 testing and in particular positive cases. So we last gave an update on 8/7 last Friday, and since then we have seen changes in the overall number tested, positive and negative. So the total number tested did increase from 19,299 to 21,076, while the number positive increased from 1,733 to 1,806. And the number negative also increased from 16,821 to 18,523. So this slide just depicts the cumulative incident rate within our region. We do provide a breakdown of this rate by USET counties, USET states, and then compared to the overall rate in the United States as a whole, as you can see. The number of confirmed COVID-19 cases is still climbing, so you are able to see that as predicted. And with the cumulative incident rate being highest among USET counties, followed by states, and then the United States. So we are seeing higher rates within our region, as you can see. And just a reminder that this graph is included in our USET aggregate report, and that we send out tribe-specific COVID-19 surveillance reports every Friday afternoon as well. So be on the lookout for that today. And then I'll just close with another reminder that we are still offering the USET TEC COVID-19 surveillance tool to tribal nations to assist with tracking COVID-19 cases. If you are interested in this tool or have questions or concerns, please feel free to reach out to us at usetinc.org. Thank you.
Thank you, Imani. Do we have any questions for Imani before we move on? Okay, thank you for a great presentation, Imani. We'll move on to Dr. Bunio.
Good morning, afternoon, everybody. Thank you for having me. I'm going to share my screen and give a short presentation. I think it was titled something about best practices. I don't know that these are best practices. These are just kind of our story here at Cherokee Indian Hospital, Eastern Band of Cherokee Indians. And I hope that people can find some value in what we did and what we learned over the last several months. I'm not an expert. I'm a family physician. I'm learning just like everybody else as we go along. So let me go ahead and share my screen. And can everybody see that? Okay, so just to start off, you know, I got this quote from one of the many webinars that I attended, and the rules of an epidemic: a day is an eternity. Each day, take your best shot, make a decision. As the facts change, take another swing at it with those new facts. But you must make decisions, and indecision is deadly. So I'm going to be just sort of presenting from the perspective of the Eastern Band of Cherokee Indians and Cherokee Indian Hospital Authority. I'm going to give you a little bit of background, look at a real quick timeline, tell you about how we built our team, our communication strategy, how we responded to danger that we perceived in the community, and just a few lessons that we learned along the way. So as many of you know, we're located in Western North Carolina, and roughly we have a population of 12,500. The Eastern Band of Cherokee Indians, the main Qualla boundary, actually straddles two counties, Swain and Jackson, but there are little pockets of trust land over in Cherokee County and Graham County. Archizda, of course, is 5 counties, and this is important because of, you know, sort of the way that reporting of COVID going to all the county health departments was a requirement. So even though we have our own public health department here, a tribal public health department, all positive cases would go to that department and also to the county that person lived in. So again, everybody knows a lot of this. Around early January, things were heating up in China, a global health emergency and public health emergency were declared. The tribes brought together their EPI team on February 14th, and the hospital, the executive team started meeting about this on February 21st. The red items are tribal, and the green items on this list are the hospital. So then the CD said COVID-19 is heading towards pandemic status. The hospital created our response team to just, again, continue planning for what we saw coming. And then on March 11th, the WHO declared it a pandemic. And on the 13th, President Trump declared it a national emergency. So both the tribe and the hospital decided to use the incident command structure to prepare for this. And so the tribe stood up their incident command, which included the hospital, as well as EMS, police, fire department, schools, pretty much everybody. And then the hospital decided that internally we would use that same structure to build our teams and create our response. And then on March 26th, the tribal leadership decided to close the Qualla boundary so that you could not enter the boundary unless you had business here, you worked here, or you were a member of the tribe. Tribal members could come and go as they pleased, but this pretty much shut down tourism. The casino was shut down, and this was in those early days when everybody was really nervous and everybody was, you know, just scrambling to protect. A number of other counties near us also, you know, tried to close their borders. So this is just a real simple snapshot of the incident command structure that we built. Originally, it was divided into a planning branch, operations, communications, and logistics. And I'm going to talk mainly about the planning group because that's the one that I was in charge of. So planning was divided up into these different groups: screening and testing, protecting health services, isolation and quarantine, care and treatment, and surveillance and containment. We also had a public information officer assigned to this group. So as we built this out, we actually took, we found that isolation and quarantine, we moved that in to the infection control group under protecting health services. And so then we pared it down to screening and testing. And they were responsible for developing our hotline through which our community could access testing. They built a testing team that did both for cause, if you will, testing and also community surveillance testing. Anybody that wanted a test could come and get one done. And they also were mobile. They could move to one of those parts of those outlying counties and outlying clinics if we had a hot spot and we needed to get a bunch of testing done. I'll talk about them a little bit more in a sec. The Protecting Health Services group, they brought infection control under them. They were responsible for PPE conservation. They developed our screening at the doors of our clinics and on our main hospital campus. And really, you know, a number of things, and you know, including return to work policies. We developed a travel policy for our staff, trying to educate them on what we considered safe travel and unsafe travel. And so they actually did quite a lot more than I was able to summarize here. The care and treatment group initially spent a lot of time worrying and working on how our inpatient unit was going to respond to a surge in COVID cases. We have 18 beds. We don't have ventilators. So far, we have not really needed to deploy any of that in Western North Carolina. We've been pretty lucky. And we have other partners that have taken our coronavirus cases that need inpatient treatment. But they also worked on developing outpatient protocols and have spearheaded some temporary housing that we can use for people who are COVID positive, who are either in multi-generational families and want to get out of there, or if they're homeless. And I think the homeless population was our biggest concern. And members of the addiction and recovery community who tend to couch surf a lot and pop from house to house. The surveillance and containment group, they early on, the county health departments were pretty much overwhelmed, and it was a little chaotic initially. So we developed our own contact tracing team, and we also did a lot of education, not only with the with people who are COVID positive, but also the PUIs. Originally, everybody that got a test was considered a PUI. So we wanted to kind of connect with them early on, even before we knew if they were positive or not. So this group has met weekly since the beginning. We talk about the plans they've completed. Once the plans are completed, they're handed off to the operations group. And I will say, for practical purposes, the people that did the plans then moved over and they were in the operations team. So the people that built the screening and testing site, they just moved over and they operationalized it. So screening and testing, I want to talk about that one a little bit more. They developed a drive-through testing model at our outdoor drama site, which was shut down. So we had pretty good traffic flow. There was some cover there. We utilized manpower that otherwise we would have furloughed. When this all started, patients just stopped coming in, like everywhere else. So this was an opportunity to keep a lot of our staff working and employed. And we really offered testing to anyone who lived on or interacted with this community. So if you were an enrolled member, obviously you got tested. But if you were the boyfriend of an enrolled member, if you came and went off the boundary, we would go ahead and test you. We really, early on, we wanted to know what was going on in this community. And so we were pretty liberal with the tests. You can see month to month how many tests we were able to do and the positive to negative ratios. We had a little bit of so we're up to over 7,000 tests with a population of 12,500. Some of these, of course, are repeat tests. We saw a bit of a spike in July, and we'll talk about that a little bit. But some of that was when a lot of employers were insisting on the 2 negative tests before they would allow somebody to return to work. As we've shifted everybody more to the symptom and time-based strategy, and so these people were just they're testing positive over and over and over again. And when we were struggling to get our tests back, we were getting people coming in to be tested like every day, even though the first test hadn't even come back yet. And so the number in July was a little bit elevated, but it also does reflect disease activity. So winter is coming. This is what I keep telling everybody, and we have started our planning for what are we going to do in winter. We're going to move from it's too hot to wear all this PPE and I need to take a break to it's too cold to be outside, you know, and so we're going to have to shift our strategy a little bit. And so what we're planning to do is move from a drive-through model to a drive-up model, where people will drive up, park, someone will come out, we'll do whatever tests are ordered. We want to move to more of an appointment-based strategy and less community surveillance. But we're not only going to do COVID tests, but we're going to do flu tests and strep tests and anything else that we can. And like everybody, like a lot of other places, we've stood up virtual visits and we have a virtual urgent care. So this would give that provider the opportunity to say, okay, I just need a strep test on you, and then I can still treat you virtually. So they can go to this drive-up testing site, get the test done, and then, you know, we get that result back to the provider. We're projecting that we could serve up to 50 patients an hour in this model. And we're also thinking that we can pivot this to provide mass immunizations for flu. And, you know, as soon as, you know, Russia gives us that really great vaccine that they have, we can pivot to start using it for mass immunizations for that. So the surveillance and containment team, I want to talk about them a little bit. So early on, we started calling everybody who got tested. We gave them education. We told them how they could, you know, protect their families, isolate themselves just until their test came back. We also reviewed their contact list, and we started developing contact lists for them before we even knew if they were positive or not. And then we just check on how they were doing. Initially, when the numbers were low, we did this daily, but then that became unmanageable. And we scaled that back to just one call after the test was taken. And then when we got a positive, we were able to hand off a completed contact list to the tribal and county health departments so they could get a jump on it and start doing their contact tracing. If a patient was symptomatic, we handed them off to their primary care team, who were responsible for monitoring the medical status of the patient. And they would call them every day or so and just see how they were doing. Did they have enough medication for their isolation period? You know, did they need anything that we could provide that would allow them to stay isolated? And then we also notified patients of all the negative tests because, of course, they were nervous. Okay, so winter's coming for this too, and our strategy here is we're just going to hand this over formally to the public health department here on the boundary, and this is going to release all those staff that we deployed to this back to their regular jobs, because now our patients are coming back, our visit volumes are back up, and we need people back. And as of yesterday, we found out that North Carolina State was going to give us 10 contact tracers that they were going to hire and pay for, which we were very grateful for. So that's going to really help us so that our public health nurses can be contact investigators, and they can go out into the community. And I'll mention one time where that became important. And we've got trained contact tracers that can help us do this work. I want to talk a little bit about how we communicated all this. So this just sort of this comes out 3 days a week, Monday, Wednesday, and Friday. And as you can see, it's a symbol of the partnership we have between the hospital, tribal leadership, and the Eastern Band of Cherokee Indians Public Health Department, Public Health and Human Services. So we started off, we're sending out the same kind of snapshots of demographic data, but we've got by age group, and they wanted to know, the community wanted to know how many cases were in each community. We divided up by gender, but a lot of us felt like this is a snapshot, and it wasn't really communicating to the community are we headed in the right direction or not? So we started using this, which is basically showing a trending of total positive, total recovered, which kind of parallel each other and go up. And this is cumulative. So we expect this one to go up. But then the sort of green line, which is the number of active cases, we wanted that to stay flat or go down. And so we said, well, this kind of gives the community a sense for where we're going. And then we got really excited. The nerds in the group got really excited about using this, which is daily new reported cases per 100,000 on a 7-day rolling average. And so Cherokee Indian Hospital is the red line, North Carolina is the blue line, and Western North Carolina is the green line. And this also gave us, and I'll tell you, I'll show you in a bit where we got this from. It gave us these warning levels, COVID risk levels. So everybody knows green, yellow, and red. And we also had orange in here, and that was based on the number of cases per 100,000 on this 7-day rolling average. Now, when you have a population of 12,500, you know, one case is kind of like 8 cases per 100,000. So the graph jumps around a fair bit, but we wanted to do this for several reasons. One was, at its simplest, most basic level, we can communicate to the community we're red, yellow, or green, and then of course we threw orange in there, and everybody, we thought, could understand that. If you didn't even look at the graph and sort of get confused by it, you say, okay, we're at red, that's worse than it was last week when we were orange. Or we're yellow, that's better than it was last week. The graph itself foreshadows trends, which we hope are going to influence behavior in the community. So if we're doing worse, we want people to buckle down and do what we want them to do in terms of wearing masks and social distancing and stop having cookouts and things. And it provides a comparison to how we're doing compared to the state and the rest of Western North Carolina. And if tribal leadership had to impose stricter measures, it shouldn't be a surprise. We were foreshadowing, hey, things have been getting worse now for a couple of weeks. And we hope that that would decrease the lag time between any executive order and the implementation. If you're going to shut down, you know, restaurants or gyms or whatever, a lot of times, you know, there's this lag time before you can put it into practice. So that was one of the reasons. And I've got the reference for this, and it came from the Harvard Global Health Institute. This is where we got this model. They give us these kind of general, you know, guidelines about what to do when you're at different risk levels. So one of the things about this, so it's pretty obvious, you know, when you're green, you just keep doing what you're doing. When it's yellow, you ramp that up. When it's orange, if you've got a rigorous testing and tracing program, you can keep things going. But when you get to red, you should consider a stay-at-home order. An important point about this is we do not communicate that when we get to red, there's going to be a stay-at-home order. Tribal leadership did not want to be tied to feel like they were forced to do that. But we still thought that the colors were valuable, that we could communicate this to the community. So this is me communicating risk level. I do a weekly live stream, and my wife has given me masks of different colors. So happy to say we were at level red 2 weeks ago, and we are now at level yellow. So that's one way that we communicated, apart from sending it out on social media. So what are we going to do when there's an outbreak? So I went back in time. We didn't even have this model, but I went back in time, and you can see that around the 26th or 28th of May, something happened, and we got this big spike in cases. So what happened then? Well, we had some cases that we thought, and actually did, have a lot of potential exposures. So we developed what we call the situation team. We call this team together when we see cases that have the potential for triggering a big outbreak, especially if their contact list is thought to be incomplete. This can happen at large gatherings, funerals, church services, or if somebody just isn't cooperating and isn't giving us a contact list. So somebody, either their memory's not that great and we don't think they're giving us all the contacts, or they don't remember them. So we bring together this team that has executive leadership, the Joint Communication Committee, public health, and hospital. And we meet twice a week and we share information. It's amazing how many times somebody on the call says, I can't get a hold of this person, and somebody else knows that their uncle, you know, works at the Dairy Queen. You know, I don't know. There's just community knowledge out there that we drew on when we thought we had a situation that threatened the community. Also, people will come to the drive-up testing service and they will say, I'm here because I was a contact with Bob. And Bob didn't tell us that this person was a contact, so we can supplement and add that into our contact list. And so again, it's all about communication. And then for those cases where it's impossible for the individual to tell us who all was at that funeral or big gathering or church service, we recommend a public service announcement, which says, hey, if you were here on this date, you may want to consider getting tested. So here's a situation that happened. We had a couple who attended a funeral, and they also attended, apparently there's a dinner for the grave diggers before the funeral. This is something I'd never heard of before. And then there was a church service afterwards that they attended, and masking and social distancing were not practiced. So they had 21 potential contacts. 4 of those ended up being positive. So then we traced them. Whenever we got a 0 on the positives, that stops this tree from building. But they had 4 positives. 3 of those ended up infecting 2 other people. And then there was another couple that ended up infecting 4 more people. And at that point, there's a red box here because that person didn't give us very good information, but we were stuck. But every other one of those contacts, we didn't get any other positives. So at that point, we were able to shut down this situation. There's another example. This is somebody that tested positive and gave us a contact list, but we later found out that the contact list wasn't great. And 4 of the contacts lived in the same household. They turned positive, and none of them would talk to us. So these were, and in fact, they wouldn't even come to the door when we tried to issue their isolation order. These are members of the addiction and recovery community, and I'm pretty sure that they weren't going to tell us who their dealer was, or they were afraid that somebody was going to get in trouble. But in this case, we just got stuck. We could only go so far. But our response to this was we took our testing team over to the needle exchange, and we offered tests to everybody that was coming by there. And we did not see this one grow. So knock on wood, I think we dodged a bullet there. Okay, so what did we learn? Support from leadership is critical. Tribal leadership, hospital leadership, they knew that this was important, and they listened to the medical providers. When you make an overly cautious decision, you never regret it. I mean, we were probably closing down the border, might have been a little bit much in retrospect, but it sure communicated to the community that this was serious. And it also stopped tourists from coming and buying up all the toilet paper at the food line. Every team needs a black hat. If you're familiar with De Bono's model, the black hat person is the one who says what could possibly go wrong. And I was fortunate to have several black hats in this team who were always thinking about what could possibly turn into a disaster. Communication and collaboration between tribal, hospital, state, and the counties was incredibly important. It's still not perfect. The counties were struggling. We had a lot more resources than the counties did. And so they actually, I think, appreciated us helping them. Take the information wherever you can and act on leads. Again, you know, if we heard something, we would track it down. You know, if we heard a rumor, we would try to find out anything that was a potential threat to this community. And you can never over communicate simple messages. So here in North Carolina, we have the 3 W's: wear a mask, wait 6 feet apart, and wash your hands. And this comes from North Carolina Department of Health and Human Services. So we pulse those all the time. And then if you're lucky, you may find yourself being immortalized in a cartoon image and with a message. So originally I had used this in one of my broadcasts to say, I'm tired of singing happy birthday in my head. So I was actually using Keep Your Hands to Yourself by the Georgia Satellites and singing that to myself. But we also like Don't Stand So Close to Me by the Police. And then this was right around when the police weren't behaving very well. So I said, well, let's not say this comes from the police. And so they changed it to Sting. And these billboards are now out and with my face on them. And if it works, I'm happy to do it. That's all I have. So I'm happy to take any questions.
Great. Thank you, Dr. Bunio. Do we have any questions at this point?
Well, I just have a comment. That was a wonderful presentation. And if you claimed you were not an expert before you started, well, I will promote you to an expert after your presentation.
Thank you.
I have a question. When you went to the needle exchange, I mean, did you experience some sort of reluctance there as well for people to participate? And did
Yes.
Okay.
We did, because the needle exchange is anonymous. I mean, let's face it, this is a small community. Everybody knows who everybody is. But in order to do the test, we needed to know who they were to get the results back to them. So yeah, we did experience reluctance there. What we did find was a lot of the members of the addiction and recovery community were spontaneously coming up to our testing site, because early on, we didn't put any barriers to testing. We had enough tests. We were really lucky. So a lot of them had already got tested anyway, but it did give us an opportunity to give them that education about, listen, we know you're going to be using, these are some ideas about how you can stay safe.
Great. Just a reminder to sign in on the link in the chat box. And if there's no more questions, we'll move on to Dr. Mira.
Okay, thank you. So I'm just turning my phone off. So if you were present on the Portland COVID, this is the same presentation, so I apologize to bore you for the second time. But you know, every time I give a presentation, I learn more from it. So I think I do a better job the second or third time than the first time. So that might be a benefit. Okay, so there's three subjects I'm going to touch today, which I found interesting. You know, the literature, it's difficult to follow. It's very abundant. There's a lot of stuff that needs to be weeded out. And I try to bring what I think could be interesting, which does not necessarily mean it's going to be interesting. Anyway, so, you know, we know that there's a lot of debate in the media and also in the professional circles about PEDS and COVID-19. So this, it's not a research study, it's more like a hypothesis, but which I found, you know, fairly interesting. And although this was done with data that we had in April, which is several months ago, it still applies because the percentages really haven't changed so much. So the premise is that in April, of the 150,000 cases of COVID, only less than 2% had affected children or individuals less than 18 years old, despite the fact that they can make 22% of the US population. And when we look at other respiratory infections using global data, in 2015, out of the 290 million episodes of lower respiratory infections, 1/3 were in children less than 5 years old. And that caused over 700,000 deaths in this group of children, and about 6% were due to RSV or influenza. So there is a question like, why is this virus infecting less children than other viruses do? And also, when you look at the graph on the right, this is a very simple graph showing that if you're an elder, you have a high chance of developing a very severe illness. If you're a young adult, there's a chance, but that's lower, it's probably less than 20%. If you're a child, still it's less than 2%. So children in some way apparently have less infections and definitely less severe infections than adults do. Now, this may change over time as we collect more data and we start, seeing reports lately that, children may be, colonized as much as adults are, but that's still up for debate. So what could explain this difference? This is an illustration of an adult lung and the pediatric lung going down to the level of the alveoli. So this is your alveoli. This is the capillary that feeds the blood to that alveoli. So normally oxygen comes through here and it gets through the membranes of the alveoli and the vessels. And that's how we oxygenate our red blood cells. So what is different from a child compared to an adult? Well, first, the virus needs ACE2 receptors and also a host protease, which is called TMPRSS2, which primes that ACE2 receptor so it can bind the virus and the virus can internalize into the cell. And one fact is that children have less ACE2 receptors and less TMPRSS2 protein to do this. So this could be a plausible explanation why if a virus hits the alveoli of a child, it has less chances of the virus replicating, or if it replicates, it may replicate at a lower viral load. Then the second factor is the immune response. In adults, usually there's a lot of cytokines that are being produced, but the major ones are IL-6 and tumor necrosis factor alpha, which they are pro-inflammatory cytokines. So they generate a lot of inflammation. And there are mechanisms that regulate the amount of these cytokines are produced. And some of these mechanisms are tied to other cytokines, which are IL-10 and IL-13. Well, a fact is that adults produce a lot more TNF and IL-6 than children, and children produce a lot more of IL-10 and IL-13 than adults. So it's like children have a more regulated cytokine production, which turns out to be less inflammation than adults do. And the degree of inflammation will affect the membranes that divide the airspace from the blood vessels. So an adult has more chances of altering this barrier and causing red blood cells to leak and clots to form on the vessels because they have a higher inflammatory response. So this could be a plausible explanation why children may have less viral replication, and when they do have viral replication, the inflammatory response might not be as great. Now, we all know that some children get really sick and some children even die. And Dr. Brown is giving us really great lectures about Kawasaki-like syndromes in children. So it's not that everybody will respond the same, but it's just the proportion that is different, at least so far. Okay, switching gears to masks. So, it's very interesting. We've had a lot of recommendations come from many institutions like CDC, Infectious Disease Society of America, et cetera. But when you look at where does this data come from, I would say that mainly it's expert recommendation based on some studies that most of them were not even done with SARS-CoV-2, were based on PPE use in the influenza epidemics. So there is conflicting advice about physical or social distancing. There's more debate in the public than in the scientific arenas regarding the protection that masks may confirm, as well as eye protection. But these authors, that most of them are from WHO, concluded that the recommendations about social distancing, use of face masks, have to be based on the best available evidence. So what they went out to do is let's gather that available evidence and see what recommendations we can make based on what we know. So what they did is they started a study which was very well designed, and it was based on literature review, but they only included manuscripts that precisely defined a COVID-19 case either by a PCR or had a WHO case definition. They only included coronaviruses on the study. They included COVID-19, SARS, and MERS. They excluded any studies that looked at influenza or other viruses. The study also, the manuscript also had to define not only what they considered a COVID case, but also the people who were in close contact to that case. And they looked at the distance that that contact was from the case. And they also looked if the contact was wearing a mask, if the case was wearing a mask, what type of mask were they wearing, and also if they were wearing eye protection or not. So the aim was basically to define what do we really know about coronaviruses and the protective impact of distancing, masks, and eye protection. And they looked at different types of masks. And what really caught my eye that I took a deeper dive on this study was that they included cloth masks. And we know that the CDC recommends cloth masks for the public as a source control. But I've always thought, well, not always, but recently it came to my mind based on a question that I was asked. Why does the cloth mask only protect the virus, the droplets going one direction, but don't protect the virus, the droplets coming from outside towards the person? Why don't they confer protection? So, I think this study was the only one that looked at the impact of cloth masks in their evaluation. So this is just to give you an idea of how extensive this study was. So they looked at over 27,000 publications, and then they started weeding them out based on their inclusion criteria. And they ended up with 44 comparative studies, that they included in their meta-analysis. Interestingly, they could not find one single randomized control study. So all the data that we have is based on either observational or retrospective studies. And they do mention, at the end, that it is important to have randomized control studies, and that there are 2 underway, but they did not give the details of what these studies are looking at exactly. So in summary, the study was to look at distance, eye protection, and mask on infections due to coronaviruses. This is just a snapshot of one of the many tables that are in the manuscript, and whoever's interested in the subject, I do recommend you read this. It takes a while to digest because there's a lot of data on it. But just to give you an idea, these authors looked at the number of patients that were enrolled in each study, the country that it was done, if it was healthcare or community-based study, what virus was the one that was being looked at, and if they had a confirmed WHO definition for a case of whatever virus it was, COVID or SARS or MERS, and if they had done intense statistical analysis to adjust the results, and also the risk of bias of each study. The more stars you have, the less biased the study was. And this evaluation of bias was based on a certain method. I'm not an epidemiologist or a statistician, but it seems to be, from what they report, the standard method of evaluating bias on a study. So this is just showing like one of the graphs in which they compare N95 respirators or similar versus no face mask, or surgical masks or similar. And this similar is some cloth mask versus no face mask. And as you can see, this line would be the division between the mask helps on the left or the mask but does not help on the right. And most of these studies found some impact of wearing masks, some more than others. But what I found very interesting is that even when they looked at studies that compared cloth masks to no mask, the cloth mask did confer some protection to the individual wearing it regarding of not getting the infection. This is the chart that, or the table that summarizes the whole study. And they looked at physical distance. What they found was that actually 3 feet distancing between an infectious person and a contact is helpful in decreasing the rate of infections. But the more distance that you have, the better. So 2 meters or 6 feet are better than 1 meter or 3 feet. And they looked at up to 3 meters. So being 9 feet away from someone gives you more protection than 6 feet away. And the most important thing is that if you have to choose between distance, face mask, or eye protection, let's say you're in that bind, like Dr. Bunio was saying, you have to make a decision. You only have one of these three. Which one would you choose? Distance would be probably the best one. It has the strongest impact on preventing infection. I think this is important because, you know, we had a little battle in our system of trying to convince providers to do telehealth instead of face-to-face visits, even within the clinics. So the patient was in the clinic, the provider was in the clinic, but we still promoted, try to visit with the patient through the video, not being in the same room as the patient. And of course, if there was something that needed to be done, you can, like, let's say you need to listen to their lungs, do the whole visit outside, just go in 1 minute, listen to their lungs, and the exposure is going to be less than if you do the whole visit in the patient room. So physical distance, as you can see, using 1 meter, 12.8% of the patients that were with closer than 1 meter got infected, compared to 2.6% of the patients were farther than 3 feet apart. And as I mentioned, when you increase the distance, the rate of infection decreases. Regarding face masks, there was also an impact on favoring use of face masks. What they also found is in general, N95 seemed to be better than surgical masks. And surgical masks were better than other masks, but all masks conferred some protection. They even looked at N95s in settings in which aerosols were not being produced, and they seemed to give a little better protection. Now, this could be just a surrogate marker of a more obsessive provider wanting to use an N95 and taking all the other precautions than someone who doesn't feel the risk is so high and just using a surgical mask. So there are some biases into it, but this is the best data that we have. And also eye protection helped. People who did not wear eye protection got 16% were infected, compared to the ones who wore eye protection, 5% were infected. And they also found this to be true in non-healthcare settings. Now, we're not offering or recommending using face shields or goggles in non-healthcare settings, but maybe we should in some settings. For example, households, when there's an infected person that's doing their isolation in the house, and we know that households have the highest rates of getting infected. So maybe if the eye protection is available, we could recommend it in those settings. This is just my opinion. This last thing I said, it was not on the article, but I found that interesting that this is something that needs to be looked at. So what are the implications of this evidence? We go to, for example, healthcare workers and administrators. So before we go into that, as I already mentioned this, the current policies of at least 1 meter physical distancing, and we're using 2 meters, you know, and that's fine because it's better than 1. But even if you can boil it down to 2, 1 would be better. And this is a good example for schools. Let's say you have a school that you cannot separate the kids 6 feet. If you can separate them 4 feet or 5 feet, that's better than a 2 feet distance. So distance is the most powerful protector right now regarding infections. So for healthcare workers and administrators, N95 respirators might be more strongly associated with protection from viral transmission than surgical masks. Both N95s and surgical masks have stronger association compared to single layer masks, but single layer masks also did confer some protection. And eye protection might also be at substantial protection, so that needs to be used as much as possible. So for the general public, again, distancing is very important, but also there was some protection for reusable cotton layer masks. They mentioned a 12 to 16 cotton layer. I have to look at the definition because it's not wearing 16 masks of the ones that we conceived, or else it would be impossible. I think it's just the way the cotton is threaded. I have to take a deeper dive into this part of the report. And eye protection is typically under considered and can be effective in community settings. But this is, I think, the most relevant and important message. However, no intervention, even when properly used, was associated with complete protection from infection. So other basic measures like hand hygiene are still needed in addition to physical distancing, use of face masks, and eye protection. So I think this is important because sometimes, professionals in the health setting are desperate to get one item. Like, we want N95s, okay, it's fine. There may be more protection, but do not disregard the other things. Distancing is actually more important. Eye protection is also important. So don't just walk into a room because you have an N95 and spend 20 minutes with a patient within 3 feet without eye protection, because you are going to suffer from that. And also hand washing is very critical. And finally, they conclude that robust randomized trials are needed to better inform the evidence for these interventions, but the systematic appraisal that they did of currently available evidence might inform interim guidance. So this is the best we have right now, and I recommend that all of you have decision-making powers in your systems regarding mask, eye protection, distancing. I would recommend you read this study, take a deep dive on it, and I think you'll be better informed when you have to inform other people. Okay, last I just want to touch, this came because someone in one of our previous echoes asked me, so what is the difference between COVID-19 and influenza regarding the damage it causes on the lung? And there was a very interesting, small but very well done manuscript published in New England Journal of Medicine, in which pathologists compared 7 lungs of patients with who died of COVID-19 to 7 lungs of patients who died of influenza. And they also had some age-matched controls of uninfected lungs of people who died of other things. And they did a lot of their little techniques, not little, but sophisticated techniques on all these specimens, including using molecular tools to see which genes were expressed regarding angiogenesis in different lung tissues. So in summary, I mean, these are the results. What they found is that in both COVID-19 and influenza-associated respiratory failure, all patients had diffuse alveolar damage with perivascular lymphocyte infiltration. But what they found different in the COVID-19 patients was more on the vascular side. There was severe endothelial injury, widespread thrombosis, alveolar capillary microthrombi, and new vessel growth or angiogenesis was more frequent in COVID-19 patients than in influenza patients. So the vascular component was the big difference between these two patients. And here are some images. So the other thing they found that the lungs of COVID-19 patients were heavier and probably stiffer than the ones without COVID-19. And here you see the lymphocytes, the little black dots infiltrating around the vessels. And you see these inflammation inside the vessels. They call it endotheliolitis. This was not present in pneumonia patients with influenza. The other thing is that this is, let me walk you through the image. This is the alveolar septum. This is the alveolar space. This is where the vessels go. And you can see a thrombi inside the vessel. That was very common in COVID-19 patients. They basically clot the blood inside those capillaries. They also found a lot of fibrin in the alveolar space, more in the COVID-19 patients. And that could also explain the severe hypoxemia some of these patients develop, because the oxygen has to go through this fibrin layer and then get into a blood vessel that is clotted. And also the membranes are disrupted and the red blood cells fill up. So it's really a mess of abnormal blood vessel structure on COVID-19 patients. And when you look at this electron microscope, this is like seeing the alveoli, but only the vessel structure. They ripped up the epithelial cells. And this is a normal alveoli vessel structure. And this is one hit by COVID-19. And you can see that it's completely disorganized. And there's all these little spikes coming out of the blood vessels that you see here. Those are signs of the pathologist calls of angiogenesis or new vessel formation, but the new vessels are distorted and anatomically abnormal compared to a new vessel. So that's all I have, excuse me, for you today. And if there's any questions, I'll be happy to answer them if I can.
I believe there's one question in the chat. How effective are surgical masks that some people continue to rewear for months?
Not effective. I mean, you can't have a surgical mask and we wear it for months. You know, the mask, there's a point in which the humidity dampens them and alters the filtration capacity of the mask. So you shouldn't use the same one for months. You should, you know, masks are, according to the manufacturer, they may be slightly different. So my recommendation is look at the manufacturer instruction to see how long you can use them. We have a little bit more evidence on N95s because they're more standard the way they're built. And N95s, you can use them for a whole shift if you don't take them out. If you don't, you know, take them out and put them in, take them out and put them in. You could reuse them up to 3 to 5 times, as long as you're very careful not contaminating yourself when you're taking the mask off and on. And there's some techniques that are published on how to do this. Actually, we have a video that we used at Cherokee Nation at the beginning when we were not having enough N95s on how to reuse your mask. But there's less transmission when providers use the N95 the whole shift than when they're taking it off and on and putting it back on and off. With surgical masks, they're intended for single use, but you would have to look at the manufacturer, but it may vary.
Dr. Mera, so we're encouraging universal masking, and early on we also tried to do social distancing as well. But because of the structure of our clinic, it's a nightmare, right? We built our clinic so that we had an integrated model and everybody was close, right? And they could talk to each other, which was just a perfect storm for COVID. So if we're enforcing universal masking, how much extra bang will we get out of adding social distancing on top of that?
Well, okay, so according to that study, the study that I just mentioned, but I just kind of give you the bullets because it's a long study, they found a higher impact on the distancing than on the mask use. But combining things are better. So if you can do all three, that's your best. I mean, all three plus hand washing, that's your best shot. If you have to choose one, like I said, distancing is probably the most important. But I mean, I agree with you with the mask. I think you should not go back and go away from universal masking. You should continue that. You need to work a little bit more on the distance as much as you can. And I understand what you're saying because, you know, things are easier said than done. But sometimes, at least in the clinic, if expanding the hours of the clinic and diluting the people that come in on the same day and different times, using more telemedicine within the clinic, you know, that also can help that contact. Yeah, you have to use, it's very difficult for me to give a recommendation on a different clinic because you know that clinic better than anybody. And you know what can be done and what cannot be done. But you have to do what you're doing, is using your imagination as much as you can, and you know you'll have limits. And but just do the best you can and keep. But let's say you can't put chairs 6 feet apart. Well, at least put them 3 feet apart, because that will have an impact.
Great, thank you. Just a reminder to fill out the survey in the chat to receive CEU credits. Do we have any other questions for Dr. Mera or Dr. Bunio? Okay, great presentations all around today. Thank you all. Have a great Friday.
Bye-bye.